Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with an extremely narrow ear canal. You may have just noticed that as we were entering with the fine end suction probe. And because of their narrow ear, they get this chronic buildup of earwax and dead skin that needs to be removed on a regular basis, typically every year. You can see I've just put some oil in here, and that gives you some perspective of how narrow the ear canal is. And the fine end suction probe just about fits into the ear. And the reason for the oil is because this wax is quite sticky and stodgy and glutinous in consistency, and it can make it difficult to vacuum because first of all, you don't get a suction grip, and secondly, quite often the soft sticky wax, when it travels up the tube, the suction tube, it gets blocked. So the olive oil spray really helps to bind this wax. I always compare olive oil spray in the ear, I always compare it to an egg in a potato cake or fish cake recipe, for example. It helps to bind all the ingredients together, and in a similar way, the oil helps to bind the wax together. In addition, the oil helps to lubricate the inside of the suction probe, so it prevents blockages when wax is travelling up. And of course, it helps to lubricate the ear canal wall. That reduces any friction as you're extracting the wax. Now, if you continue to watch, this is their right ear, and it's their left ear that's really, really interesting. And for the reason being, and you may have noticed the thumbnail, the video name, I've seen it once before, but this is the second time. Their eardrum has got a retraction, but it's in a peculiar position. Normally, when you have your eardrums buckled inwards, what we call retracted, it's normally in the attic, or what we call the pars flaccida, the top part of the eardrum, where the eardrum's a bit thinner and it's more prone to buckling inwards in response to middle ear pressure changes. But this was more centrally, and it was quite a deep retraction. It was only a small one, mind you, but within that retraction pocket, there was a buildup of dead skin, and this skin couldn't escape. It got trapped, and it was protruding outwards, out towards the entrance of the ear canal. And when I removed this dead skin, I compared it, I showed it to my clinic manager today, and I was trying to explain what was going on. And I explained that this piece of skin that I removed is almost like one of those clip or snap buttons. So the eardrum had the female part, where there was an indentation, a retraction inside the eardrum, where the eardrum was pulled inwards. And this dead skin, it had the male portion, so it was the bit that clips into the indentation within the eardrum. So I honestly felt if I had this piece of skin that I removed and pushed it back in, it would clip him back into place in the patient's eardrum. So you'll see that in a moment. We've just cleared the ear here. You can see how narrow it is. It's slightly blurry at times, and that's just because we put loads of oil, and because it's a narrow ear canal, it can kind of graze the lens. That's the patient's eardrum. Now this eardrum too is sucked in. It was wrapped around the head of the stapes bone, so their incus bone, the middle ear bone, the second of the three, also known as the anvil, that's missing. That means like it's eroded. And they're developing what we call an autoatticotomy, sorry. So the top part of the ear canal near the eardrum is beginning to erode away. And because that bone's beginning to erode away, the middle ear features are more visible. So some features that shouldn't be visible when you're looking into the outer ear are visible, because some of the bone that hides away some of the middle ear structures is just being eroded, and that erosion can be due to the eardrum being sucked in. And when the eardrum is sucked in, it wraps around the bones in the ear canal and the middle ear, and that stops the flow of blood. So all the blood vessels get constricted, and when there's a reduction of blood, that bone eventually will die because it's not receiving all the oxygen and nutrients it requires to sustain itself. So the top part is called the scutum, and it's at the top, it's at the roof of the ear canal near the eardrum. That's beginning to erode away. Because the eardrum is sucked in, we knew that was sucked in because it's wrapped itself around the stapes bone. So just coming back to this left ear, so you can see I've cleared the entrance. Again, once again, narrow ear, I had to put some oil in. Now in the distance, you can see some dead keratin, and that's embedded onto the eardrum. But prior to removing that, I'm just trying to peel away some of this dead skin. It's semi-shedded, it's not quite shedded yet. So it's still strongly adhered to the canal wall, so you're just going to be careful, because if we try and force that skin out, it will be uncomfortable. So this skin here, think about, as I said at the beginning, like a snap button or clip button. So you've got a female part and you've got the male part, and you push the two together, and the male part snaps inside the female part. And in this instance, this skin here is the male part, and the eardrum has got an indentation, the female part. So I'm just trying to peel this away, but it's embedded. So I'm going to have to use some oil. And I was a bit worried because the eardrum, you can see the eardrum is moving there. I don't know if you've noticed that at the top, but as I'm moving this skin away, the eardrum is also pulling towards me. I don't know if you can see that. So I'm just releasing. As soon as I feel there's a bit too much tension, I'm just releasing that skin. You can see that skin, it's hanging outwards, it's extending outwards from the centre of the eardrum. So I've just put loads of oil in. Sorry, it's a bit blurry. When you put oil in a narrow ear like this, you can get a bit of blurring, because as you're suctioning, there's a lot of oil there, and the oil's being suctioned, and that can cause blurriness. But I'm going to clear that in a moment, hopefully, and so we'll just come back out, wipe the lens again. I'm just mopping up near the entrance. Some of these hairs also can attract the oil, so if you put the endoscope through the hairs, it can get oily. So the oil is still in the ear. That's the key. Quite often, when I first started performing clinical ear care, I would drain the ear of the oil and then go back in. But now more and more so often, I'm actually performing the procedure with the oil in the ear. So I've just got the patient tilted over, so the left ear, this is the left ear, is facing slightly towards the ceiling, and I'm stood up and I'm looking down and into the ear. And I'm just hoping this oil loosens the skin. So you can see there's less tension on the eardrum now as I'm pulling it. So yeah, as a patient gets more elderly, the eardrum can become weaker, so we've got to be careful. So you can see how that just came out. And you can see that hole in the middle. I'm just going to wipe the side of the canal wall because there's a bit of oil there. So the eardrum isn't perforated. It's got three membranes. The outermost membrane that's facing us is an epithelial layer of skin. That doesn't appear to be breached. Then you've got the middle membrane, it's just made up of fibrous tissue and connective tissue. And then you've got the inner membrane, which is the mucosa layer that lines the middle ear. So you can see some skin just around the edge of that hole, but not hole, indentation. I just approached it, but that's not ready to be removed. We don't want to force our luck. So I'm just suctioning it, just making contact to see what the texture is like. Sometimes you've got to touch the eardrum or certain pieces of wax to get a feel of the texture. And it wasn't ready to be removed, but I'm going to zoom back in a moment. So I'm just going back for these dead skin patches there. They're not ready to be suctioned. So in the middle, you can see that indentation. And that's like a clip button or snap button. And that piece of skin had a corresponding male part that popped into there. But the patient could hear significantly better. They have been seen by ENT, mind you, so about this condition. And sometimes you've got to be careful of an underlying cholesteatoma, but the ear was clear. I hope you enjoyed that video, guys. Do take care and stay tuned. Thanks. Bye.